order. I'd like to call the meeting to order. Welcome to the Public Accounts Committee this morning. We have with us today as a witness the Department of Health and Wellness, and I will remind those in attendance this morning to place their phones on silent or vibrate, and I'll ask, starting with Mr. McGuire, for the committee members to introduce themselves.
Good morning, Brendan McGuire, Halifax Atlantic.
Suzanne Lonis-Croft, MLA Lunenburg.
Chuck Porter, MLA Hants West.
Joachim Stroink, Halifax Shabakto.
Good morning, welcome. My name is Tim Houston. I'm the MLA for Pictou East.
Good morning, Dave Wilson, MLA for Sackville-Cobequid.
And I'm Ian Rankin, MLA for Timberlea Prospect, Vice Chair filling in for the Chair this morning. As I said, we have Department of Health with us with respect to the Emergency Department, Accountability and Collaborative Emergency Centers as a topic. And at this time, I'll ask the witnesses to introduce themselves.
Good morning, my name is Andrew Travers, Provincial Medical Director, EHS.
Emily Summers, Interim Executive Director of the Acute and Primary Care Branch, Department of Health and Wellness.
I'm Denise Perrette, Deputy Minister of Health and Wellness.
Good morning, I'm Janet Knox, President and CEO of Nova Scotia Health Authority.
Good morning, I'm Paula Bond, Vice President of Integrated Health Services, Nova Scotia Health Authority.
Good morning, Tanya Penny, Senior Director of the Emergency Program of Care for the Nova Scotia Health Authority.
Thank you. And now we can proceed with the witnesses. If you'd like to make opening remarks, is it Ms. Parrott? Ms. Parrott.
Thank you. Thank you very much for the invitation to be here. We're talking about emergency room accountability and collaborative emergency centers. So we appreciate the opportunity to address your questions, and I'll make my opening comments brief. What I want to do is pick up a bit from the last time I was here and talk about the need for change, because these topics lend themselves to that issue. And we know that health systems in Canada, as in many parts of the world, are in the process of making significant changes. And the reasons for that are increasingly clear. Canada, despite relatively large investments that its taxpayers make in health care, is not seeing the level or type of service or the health outcomes that the investment warrants. And to get better value out of the system, we have to make system shifts, and that requires that we move from a system that is relatively fragmented and disjointed today to one that is more integrated and coordinated. We need to move from a system orientation that's relatively introspective today to one that is much more collaborative and adaptable. And this is the important piece. We need to move from a very narrow concept of primary care to a much robust and broad-based view of primary health care, where the focus is on the health and well-being of individuals, families, and communities. And this means that people and systems have to organize and work differently. So there's a growing body of evidence and discourse about the need for these shifts. And increasingly, we're seeing the public and healthcare providers reinforcing the need for change. So we see, I think, an increasing number of discussions about access, about emergency department wait times, about overcrowding, about the rise and impact of chronic disease. And these are issues that have been hampering the system for years. So the discussion we're going to have today is not a new discussion. We've been having this discussion probably for well over a decade. And it's happening in other provinces across the country. And despite demands that we can address these things by just simply making more investments in the healthcare system, provinces and territories increasingly know that simply adding incremental money to the system is not the answer. Doing the same thing is not the answer. Working in the same way is not sufficient. We need to change our investment strategy. And despite the prevalence, complexity, and protracted nature of the issues we're addressing, I submit to you that the people of Nova Scotia have reason to be hopeful, and that's for several reasons. What is new, I think, is that we have a heightened sense among the public healthcare providers, system governors, of the need for change and an increasing impatience and willingness to make that change. There's a much more focused discussion and discourse about the complexity of the healthcare system and an increased momentum for change. And so I would point to the recent report, the Code Census report from the NSGEU, as part of that discussion of people stepping forward, frontline staff, stepping forward to take the time to put their experience, concerns, and recommendations forward. And it's that type of initiative that builds the momentum for change. There's also an appreciation, and you see it in the NSGEU report and in the surrounding commentary, that this is not a unique situation. And it's important to understand that as well. We're dealing with very complex issues. And there are systems out there that have been trying to make these shifts and have not done it successfully. So we need to understand that these are complicated matters that require a really focused and intentional commitment to the change. But I think what's encouraging is that increasingly the awareness of that complexity and the need for change is there. I think is also a second point I would make on why we should be hopeful is that Nova Scotia has a robust health professional workforce. We have over 40,000 health professionals. That's a good supply. And they want to work to their full scopes of practice. And we know that if we enable that through collaborative team environments, that we can improve access and we can improve care and we can improve a focus on what patients and communities need. Thirdly, we've got experience in how to do this, and this puts us ahead. We have seen the same type of change we're talking about today take place with our emergency health system. What I understand from the history in Nova Scotia is we started in the 90s with a fragmented, disjointed system of 50-odd providers. And today, Nova Scotia has literally a world-class system of emergency care. And not only does it provide incredible care, so that we have a system of emergency service that's available 24/7, we have a tertiary system of care and regional system of care that is open 24/7 that never closes. But we also have individuals within that system that proactively, with their own initiative, are making changes that improve community care and have put in place programs that we truly need to be proud of, that people from around the world come to find out how we've done it. And those are programs like the Community Palliative Care Program, about the work that we do in long-term care, programs where nurses and paramedics linked to physicians go to people's homes and assess and treat in homes, and we divert from unnecessary emergency department visits, but more importantly, give people the care and attention that they need. And that's remarkable, and people are to be commended. And it's the base of experience that I'm very confident positions us very well to meet the type of challenges and the type of system change and integration that we need to make today. We also have supporting that 24/7 811 systems that are increasingly sophisticated and connect people to the care that they need and the resources in their community. And then finally, I would point out, and I think we sometimes don't appreciate the significance of it, but a tremendous amount of effort has gone into consolidating the healthcare system. So very much like the emergency health system, we've gone from 9 districts that competed, that fragmented. If you talk to some of the paramedics that have brought forward such great initiatives for community paramedicine, they'll tell you that back in the day, you still had to negotiate that with 9 separate districts. And you'll see the fragmentation of that system, where it starts in some areas but hasn't scaled and spread yet. We now have one consolidated health authority. We're creating that platform for change, and I'm confident that we are actually going to move ahead as leaders in this country. So there is a lot to do, but there is good work underway, and we're well positioned to do it. So those are my remarks. I would just ask if Ms. Knox would like to make some opening remarks as well.
Ms. Knox.
Good morning, and thank you very much for the opportunity to be here. And so I, too, would also say that we are in a position where people across Nova Scotia have access to emergency care through a variety of different services and locations, as our deputy has described, from 911 and our top quality emergency health services system, to emergency departments at our regional and community hospitals and our specialty emergency and trauma center at the QE2 and the IWK that care for the sickest Nova Scotians. Our province is the right size, has incredible people and dedicated frontline providers, and the right foundational system pieces in place to establish a quality provincial emergency care network. And our leaders and physicians are actively engaged in planning based on comprehensive evaluation of what are our population needs and what is our data telling us about them. We are all working toward a vision of one responsive, effective, and integrated network of emergency health care with many access points and a single collective mission. That mission is to improve patient outcomes for all acutely ill and injured people in this province. Nova Scotians can be confident of the services available to them today. And for more than 20 years, we have this history of being supported by our stellar pre-hospital system. If you have a heart attack in Nova Scotia today, emergency health services and our emergency and cardiac services all work together to give you the very best chance to survive and recover. Those who are within a 90-minute radius of the QE2 Health Sciences Centre are transported directly to the cardiac catheterization lab there to open up the blocked artery. Outside that radius, paramedics give clot buster drugs in the ambulance based on certain criteria and in communication with emergency physicians, and go to the nearest centre for stabilization, then on to the QE2 if required. So we can get you in the right place at the right time. In the past 2 years, a new program has seen paramedics going into people's homes to provide palliative care, as our deputy described. What I want to talk about is that they are offering a much-needed service in a comfortable setting in their home and preventing visits to the hospital emergency departments where appropriate. More than 1,000 people have registered with this service since 2015, and paramedics were able to support patients in palliative crisis according to their care plans in their homes on 55% of the calls. We will see more of these successes as we enhance the integrated emergency care network, standardize our processes, and use effective monitoring of performance to drive continuous quality improvement for better results for our patients. We do continue to see sporadic and sometimes persistent on-plan closures at some of the province's smaller facilities and collaborative emergency centres. Year over year, the hours of on-plan closure are tracking to be slightly reduced for 16-17. The situation illustrates some of the challenges of operating a provincial healthcare system. While there has been great successes in avoiding closures at places like Roseway and Shelburne, thanks to a different approach to staffing, the regular movement of physicians in and out of our province and other dynamic factors meant we have new challenges at centres like All Saints and Spring Hill. But the integrated network of emergency care in this province never closes. The emergency departments at our regional and specialty hospitals never close, and the province-wide response capability of emergency health services never stops. While it's no secret those facilities are under heavy pressure, safe, high-quality care for patients is always our first priority, and we are constantly working to meet the needs of those we serve. Every initiative is an effort to optimize our response capacity to meet the changing demand for emergency service in the interest of safe and effective care. For example, the use of code senses is a procedure designed to move admitted patients from crowded emergency departments to the care location they require. Evidence shows that admitted patients fare far better on inpatient units than when waiting in an emergency department, and their movement to those units enables emergency staff to provide better care to the patients that continue to arrive in the waiting room. These are system-wide issues, and in Nova Scotia we are working to resolve them as a system. While the volume of income patients continues to climb in urban areas where our population is increasing and emergency departments are where the impacts are most evident, the factors and solutions are more often found in other parts of the system. So the big strides made in improving access to home care throughout Nova Scotia and speeding placement in long-term care for those who need it support the flow of patients from emergency into hospital as required and back to the community. Hospital and health system flow and efficiency is an essential part of ensuring high quality and accessible care for those who need emergency services. So in the bigger picture, our systems approach, whole province approach, and partnership with other services and institutions that contribute to the health and social and economic stability of our citizens will reduce the reliance on the hospital and emergency care and help us reach our vision of healthy people, healthy communities for generations. But when unexpected illness or injury do occur, and they will occur, our goal is to have the system design and integration, the quality and standards, and hospital efficiency and surge capacity to meet the needs of our population. Thank you.
Thank you for those opening comments. We'll have questions starting with the PC Caucus for 20 minutes. Mr. Houston.
Thank you. Thank you for the opening comments. I'd like to ask the deputy, do you watch, when the House is in session, do you watch question period, or do you get a report on what questions were asked to the minister?
Ms. Parrott.
Thank you. So I haven't had the opportunity to watch question period since I've come, but I do get a report on the questions that are asked. Yes.
Okay. You probably know that on February 16th, I asked the minister a question about Dr. Horn, the Dr. Horn situation. And I asked the minister very specifically how much the province has spent in legal fees in their continuing fight against Dr. Horn. We know that before the minister became the minister in the prior government, there was $1 million spent, but that was 3 or 4 years ago. We know there's a lot more spent. And I asked the minister if he would tell the House how much of taxpayer money has been spent in their pursuit of Dr. Horn, let's call it. And the minister said that he agreed that taxpayers have a right to know how their money is being spent, and he said that he would inform us in due course. But despite various letters, we haven't heard anything back. I'd like to ask you today if you can tell us how much taxpayer money has been spent in the Dr. Horn case.
So my understanding, and the Health Authority may have some additional information, my understanding is that certainly the legal issues affecting Dr. Horn are insured issues. It's covered by insurance, and that the taxpayers are not paying for that.
Okay. Willing to say how much the insurance claim will be?
I don't have that information.
Okay. Is that something we can get?
We'll make that inquiry, but I'm not sure.
And who would you make the inquiry of?
So the insurers involved are the insurers of the Health Authority. They're not provincial insurers, so we don't have a relationship with the insurers, so the inquiry would go to the Health Authority.
Okay. So you'll ask the Health Authority, well, Ms. Knox, will you be willing to tell us how much was spent in the Dr. Horn case? Dr. Horn case.
Ms. Knox.
Thank you for the question, and thank you for the opportunity to clarify this issue. As you know, this is a long-standing issue, so yes, we will be able to do that. But I can tell you that because of the timing of this situation, it is a fully insured issue, and so our insurers are leading that. And we didn't talk about it because, as you might appreciate, when you have a fully insured situation happening, you need to contain that discussion. So I think it is important for the taxpayers to know that it is fully insured.
And the amount, though?
I don't have it right here with me, but we can find that.
Okay. Can we get the amount before the week's over?
I'm not sure if I can do that before the week's over. It's an ongoing case, and so you'll be talking year to date, but we probably can do that. I'll do my very best.
Okay.
Yes.
Yeah, it would be good to, like these types of situations, I hear many of them where the province continues use the word vicious pursuit of a citizen of Nova Scotia well past. I've seen it with many organizations where they've lost at human rights, or they've all kinds, and they just keep appealing. It's just, at some point, the foolishness has to stop. So I'd just like to know if we could know how much money was spent on the foolishness in this case. And if you're willing to do that before the end of the week, that's great. Thank you. I'd like to ask the deputy.
So the request is, just to clarify, there isn't a timeline on the request, but our clerk will follow up with the department and seek out a written response for the committee.
Yeah, no, the timeline from my side is by the end of the week, and I think
there's been no committal for a timeline on that. You've made the request. The clerk will follow up with the department.
Let me try again. Can we get a committal on a timeline for when we can get a response to this?
Again, as chair, it's not. The question has been asked, and they will clarify in due time. You're not going to set a timeline for the department to respond.
Actually,
Mr. Houston.
Well, no, with respect, Mr. Chair, I'm asking the question of the witness if they would provide some kind of a timeline.
The witnesses will seek clarification on the question that you've asked. The clerk will follow up with the department. Mr. Houston.
Sorry, do the witnesses need clarification on the question I've asked? That's your understanding, but I'm asking the witness if they need clarification on the question that I've asked.
Again, it's not your role to set timelines for when the department gets a response back to you. I recognize that you want the response by the end of the week. The witnesses will do their best to provide the response to the committee. Thank you. Mr. Houston.
I'd like to ask the witness how long they think it would take them to respond to the request I've just made.
Ms. Knox.
Thank you for the question. As I have said earlier, this is in the purview of the insurer, so I don't know what their capability is to be able to give us this information. So I will check with them in terms of how long it will take for them to give us that information.
Okay. It's my understanding that the way insurance works is that an insured party makes a claim against their insurer. The insurer then determines whether or not they'll pay that claim. The question I'm asking you is, you're suggesting you've made a claim. I'm asking you how much that claim is. It's not up to the insurer to tell me how much you've made a claim. I'm just asking you how much you've made a claim for. That's the question I'm asking. That should be in your scope of knowledge. If you made a claim, I'm asking you how much you made the claim for.
Ms. Knox.
Okay, thank you for the question.
Okay.
I hear you.
Thank you. I'd like to ask the deputy how many confirmed cases of measles there are in Nova Scotia as we sit here right now today. I understand yesterday around lunchtime it was about 13. The media last night suggested it was 20. I'd like to ask you how many confirmed cases of measles we have in Nova Scotia as of right now.
Ms. Parrott.
So I don't have a report on the outbreak of measles this morning. I'm just looking at Dr. Travers for whether he might know.
Dr. Travis.
And thank you for the question. I don't have any intelligence on the current prevalence or incidence of measles within the province.
What's the most recent number you have?
It's in the purview of EHS. We're only now beginning to open up those linkages with public health and those conversations regarding measles, preparation for it. Unfortunately, I don't have information.
Are you aware that there's measles in Nova Scotia at the moment?
I am, yes.
Okay, but you're just not aware of how many people have been confirmed cases?
Correct. As of this morning, I am uncertain of the number of measles cases.
Okay. Well, this is interesting. We're 7 minutes in and we can't get an answer to how much you spent or how many cases of measles there are. Week after week after week, it's pretty unreal to me, to be honest. But can anyone across the way explain to me what you would do if you would like to get the measles vaccine? What do you do today, right now? If I would like to get the measles vaccine, what action should I take?
Ms. Knox.
Thank you for the question. And we have a couple of options. You can call public health, and we can provide that a number. In fact, it is in the press release that came out from our organization. So that if you have a concern, we would ask the people of this province to call the public health.
Okay, so what I did yesterday is I called 811 to see what I would do to get the measles vaccine. It was suggested that I call my family doctor.
I was going to. Okay.
What if I don't have a family doctor? Then what do I do?
Call
They suggested that I go to a walk-in clinic. What if I live somewhere I don't have a walk-in clinic? Like, it just goes on and on and on. Like, I don't think there's a clear answer as to what I would do to get the measles vaccine today. How quickly do you think I could get it if that was me on the phone yesterday? And I was told to go to my doctor, I don't have, go to a walk-in clinic, don't have, maybe go to emergency, they said, but they might not have the vaccine, they might have to order it. That might take a couple days. So how quickly could I get the measles vaccine right now if I wanted to under those circumstances? What's your thought on that?
So I would have to check that for you. What I would like to say for the people of this province, that our risk is very low. We do have a measles outbreak. It's been well described in the public. And the importance of having this conversation with the people of the province is to say we need on a proactive basis to be paying attention to our immunization. And we have very good coverage, about in the mid-90% coverage for our population. So that puts this measles outbreak at a very low risk to the population. So everywhere in this province we have an access to our public health offices, and those are the people that if you don't have a family physician, we will help you get a measles vaccination. The issue that we want.
How long it would take?
I will find that out for you. So my point is, though, it is not critical that we get it today. We are not in a high-risk situation here, but we are in a situation of transparency that when these kinds of things happen, communicable diseases, we need to tell the people of this province so that we are all educated in terms of the importance of immunization. So I really appreciate you asking me this question and giving me an opportunity to say, this is sort of like the wake-up call. These things do happen. Immunization and preventative health care is really important for the people of our province.
Okay. In December 2015, Premier McNeil was in the media. There was a negotiation with doctors going on. He called doctors greedy. He then tried to retract that. But he definitely used the words unconscionable and pay to describe doctors in the same sentence. Flash forward, current day, last week we learned that the department owes family doctors $6 million. And this is money that is owed for services that were rendered, things like home visits, nursing home visits, baby care, general things that you really want your family doctors doing. Some of the services that they're owed for go back to 2015. The amount, from what I understand, is generally paid out in January. Can you tell me if that $6 million that was reported in the media last week has now been paid?
Ms. Parrott.
Thank you for the question. So you're correct. They're not a payment for the service per se. The payment for the service is made in the normal course as physicians provided. This is a top-up payment, and you're correct. To date, it's been made, there's a process for assessing the claims for the payment and working it out, and there's a lag time where it's paid either at the end of 1 year for the previous fiscal year or in January. So two things have happened. One, in the negotiation, it was determined and agreed upon by the parties that they would switch from this type of lag time to simply adjusting the fee so that it was a more immediate payment. And those fees were agreed on by an expedited group in September of last year. Doctors Nova Scotia wanted it to go to the full fee committee, and those fees were determined by the fee committee recommendation that they reached agreement in January. And so the holdup in the top-up payment was made simply to align with the new fees taking place. So I think there was a bit of miscommunication on that front. On the Wednesday that I was informed by Doctors Nova Scotia this was an issue, by the next Tuesday, we confirmed with them that the direction had been given to Medivie for the checks to go out. So whether they're in the hands, I'm not quite sure, but that was done within that time frame.
Was that last week, you mean? I'm not sure which Wednesday.
I think it's about 2 weeks ago.
Okay.
Before you saw it in the news.
So you believe that they've all been paid as we sit here today?
I believe that I know that the direction for the payments to be made went out. I don't know if they've received them.
Okay. You referred to the NSGEU report on the code censuses, and I've talked to a few emergency room physicians over the last few weeks in particular, and I asked them, like, what is it that can make your life better? More options for patients is what they talk about all the time, because people are crowding emergency rooms because they don't have a family doctor. Probably afraid they have measles now too. So do you agree with that report that the number of code censuses is increasing?
So my understanding, so I would look to the NSHA on the trend on code censuses. My understanding is that yes, that there has been an increase in the code census.
Okay, and what is the solution to that?
So the solution is what I referred to in my opening remarks.
Yeah, but how long is that going to, like, there was lots of talk about planning and vision, and we've been hearing about this for so long.
For decades.
Yeah,
and
exactly.
across the country. So it is not, it's a complex problem. And it is people like those that undertook the NSGEU report and the people working in our emergency departments that are informing how the shift needs to be taking place. But it's a shift that affects everyone in the nature of how we work and how we approach work. So they aren't, if they were easy changes, you would have seen the changes happening by now in many jurisdictions. So
if the village keeps flooding, you could try and rebuild the village as many times as you want. But at some point in time, somebody should go up the river and figure out what's causing the flooding. What's causing the flooding is we don't have enough family doctors. It's as simple as that in my mind. And in this province, where we have a premier who goes in the media and says doctors are greedy and unconscionable amounts of pay they want, and then we have payments being, you try to rationalize the delay in the $6 million, but I mean, doctors were pretty worked up over it. So when you have all these things happening, it's got to make recruiting pretty hard. These things don't help. And we're not actually, planning and vision and all those things are great, but what we actually need is execution. And what Nova Scotians are wanting to see execution on is access to primary health care. And so it's always back to that in my mind. And I could sit here today, well, let me say, we saw an announcement last week for a collaborative care center in Digby. You're familiar with that announcement?
Yes, I am.
When will that open?
Ms. Knox.
Thank you for that. Yes, that's a very good example of whole system, Digby and surrounding areas of whole system development, working with partners in local communities and finding a solution for a broad base of population. So those physicians will all be in place by September.
September, okay.
Yeah, so they're already, and in the meantime, it's been really a very good source of support from other physicians in the Western Zone supporting that area and working together in a way that supports the population. The nurse practitioners have come in earlier, and we've
So that'll
used some
open
use
in,
of programs.
thank you, that'll open in September. What about the one in Sydney? There was a collaborative care center announced for Sydney. The minister was down there. There was a big public meeting. That was October. When would that one open?
Ms. Knox.
Thank you. So I think when we were here the last time, we talked to you about the 22 nurse practitioner family practice nurses that we were fortunate enough to get funding to hire. And so the Sydney collaboratives are part of that solution. And all of those interviews have happened now. We're getting very close to be in a position to be announcing those practitioners. So we're very encouraged.
So you're encouraged it's coming?
Yes, it takes
It's coming.
the big thing that, as we talked earlier, is not as easy. We just don't go in and say to a group of physicians, we have a solution for you. We need to work with them and plan how we work together, how we bring in with them new practitioners, what are the kinds of supports they need as a team, all of that. It takes a lot of time, you can appreciate. Many of our physicians come from a very independent practice, and we need to honor that and work with them. It can't just be that we offer a model and say this is the way it's going to be. So it does take time. The hiring process does take time, and we really wanted to do it all together so that people would get in the right place for them and not be moving around to
So with the benefit of hindsight now, we don't have that Sydney one open yet. Was it announced too soon?
I think, sorry, what we announced is that we had support to go forward, and we had an opportunity to, with the additional resources, to ask other physicians and physician groups to be participate. I don't think so. I think people need to know how long it takes to develop this. In our past, oftentimes we made solutions by telling people what would be good for them.
Well, that's exactly what happened here. That's exactly what happened here. The people of that community were told in October, maybe even before that this was going to be opened and this is the solution. And everyone stood at the podium and said, isn't this great? And now we're sitting here today, it's April. They still don't have it. It may be coming, the hiring's happening.
So,
like that's the type of false hope that I think people are tired of. So when we talk about, all the planning and the vision and the wonderful things that are going to happen, it's time to kind of stop with that false hope. Even if you announce it in Digby in April and announce that it's opening, and that's great, and everyone takes a bunch of pictures, and then the reality is it's going to open in September, well, maybe that's not too long of a, maybe that's shortening up the little thing. But I mean, certainly people's understanding when they hear this is that it's happening. and it's ready to cut the ribbon, and it's coming, and I'm going to have access to a doctor now. It's really important to people that they have access to primary health care in particular. And I just think that we know why the towns are flooding. And I don't know, as I sit here today, when that is going to be addressed. Outside of some people standing at podiums and talking about all wonderful visions and changes that are going to come, I don't know when that's actually going to be addressed. And the real problem is we don't have enough access to primary health care in this province. That is the problem that we have.
Ms. Knox, 10 seconds to respond.
We support that we need to be focused on primary health care. In every instance, that is our focus. Absolutely.
Order. Time has lapsed for the PC caucus for that round. We'll move to the NDP caucus for 20 minutes. Mr. Wilson.
Thank you, Mr. Chair, and thank you all for being here on an important topic. I was glad to be able to bring this topic forward for discussion. Emergency department accountability and collaborative emergency centers, because Nova Scotians are concerned of not only access to primary care, but access to emergency care. And this is not something new. This didn't happen overnight in the last year or even the last 3.5 years of the current mandate of the current government. This has been a concern for Nova Scotians for decades. That's why in 2009, shortly after the election in 2009, the Emergency Department Accountability Act was introduced on the floor of this chamber. It was passed in that first session, and what it was meant to do was to hold government accountable. Doesn't matter the stripe of the political party in power or not, and it requires the government of the day to bring forward annual reports to identify where we have issues of emergency room closures around the province, and not only that, the onus on the government to ensure that they're acting and reacting to areas of concerns. Over those 4 years of the previous government, I was glad to say that emergency room departments closures were down 21% in 4 years. Between 2012 and 13, closures around 15,555 hours. 2015-16, that jumped by 45% to 22,505 hours. So an increase of about 45%. So within that year, it just wiped out the benefit over the 4 years of seeing yearly reductions in emergency room closures. One of the requirements under the Act is that the health authority, and of course we talked about it was plural at that time, of the 9 district health authorities, but that Act would also pertain to the new health authority and the IWK, to consult with communities if we see an increase or an issue of closures of emergency rooms. So I'd like to ask maybe the deputy, I know the deputy's new, but the information should be there, has there been any consultation with the public, with the communities that have seen a spike in ER closures over the last 3 years? Are you able to provide us what has taken place through the district or districts prior to the amalgamation on the consultation with the community as per the legislation that was passed in 2009?
Ms. Parrott.
Thank you for the question. And Mr. Chair, with your indulgence, can I just confirm that there are 13 cases of measles in the province right now? We've just had that confirmed. To the question, I don't have that information, and I'm going to ask if Ms. Knox can comment on community consultation.
Thank you for that. Ms. Knox.
Thank you for the question, and it's a very important part of planning with the community. So yes, I can say, so areas, for instance, in Shelburne, we had created a relationship with a community advisory group with the local leaders, and so that would be part of our consultation and with many, many meetings. Areas like Spring Hill, public meetings, places like Pugwash, so just give a few examples. We've had both public meetings and but we have advisory groups in the community to work with planning around resources, and our community approach to planning would include the discussion around the access to emergency services. It's really a very important component of the work, so thank you very much.
And that's why we put it in there. I would hope, I'll ask Mr. Chair, that that the Health Authority provide us with a list of those meetings, because it's good to say, yes, we're meeting with advisory groups, yes, we've met with community, but the reason for the legislation and that requirement is that so the public can see, yes, there are opportunities. So if you could provide that, you may not have that with you today. But the interesting thing is, when we heard the opening statements, we heard things like fragment and disjointed and whole system development and other terms that I think often that when I hear that is it's almost trying to justify the amalgamation of the district health authorities in the province. And what I didn't hear are solutions. We're here to talk about emergency department accountability. We're here to talk about collaborative emergency centers. I didn't hear anything about how important the collaborative emergency centers are to rural Nova Scotia. And I look back, I know what was mentioned a few minutes ago, that it takes some time. I agree with that. But it doesn't take a full mandate to address emergency room accountability, access to collaborative emergency centers, access to collaborative clinics. In 2009, election was held. Within 2 years, so by July of 2011, election was in June of 2009, the first collaborative emergency center was open in Nova Scotia. That was a complete change in model of care and delivery of rural emergency health care. The government of the day asked Dr. Ross, a well-known, well-respected emergency room physician, to come up with how do we move forward to address an issue in front of us. I know Dr. Ross worked in every single emergency room in this province and was able to do that. He was able to consult with local physicians, local health care providers, and the community to come up with a plan. Within 2 years, opened the first one, and within 4 years, 8 collaborative emergency centers opened up in this province. So that's in one mandate. We're 3.5 years in now, and I think the first real clinic or new clinic will be supposedly in September, probably after the next election. We know in the last time that the department and the health authority was here, they mentioned there was 8 clinics now. We tried to get which ones are those? Are there any new ones? I believe that the case was no, there was no new collaborative clinics in the province, and actually used North End Clinic for one, which had been open since, I think, the 70s. So I don't take the excuse of it takes time. There should have been action from this government, and I believe the thing that's driving the delay is cost. So I'd like to ask, what is going to be the cost to the province to open up these collaborative clinics in the province? Do you have that in front of you? Is there a number figure? I can only imagine that it's going to be costly. The province is going to bear the cost of the overhead costs of these collaborative clinics. That's a shift from the current system where physicians themselves now cover that overhead cost. So do you have any data, any financial cost that this will cost the province and taxpayers? And is that one of the reasons why we're 3.5, almost 4 years into the mandate, we haven't seen one new collaborative emergency center clinic, open up in the province?
Ms. Parrott?
I don't have cost information for you today, and we'll have a look at that. But it's not just one cost figure to set up a center. There's 50 in the process of being stood up across the province. 8 of those, I think, we confirmed are already set up. So they're being built over time. They're being built in response to the specific regional and population needs of a community. So they're not all the same configuration. And I would add, because I don't want Nova Scotians to feel that everyone's standing still and looking around wondering what to do. There's a tremendous amount of activity out there that's collaborative, that's driven by frontline health professionals that I think we need to acknowledge, that is really working on the problem from the upstream side and the downstream side. And we've referred to it in brief, but the details are really compelling when we talk about what paramedics working with nurses, linking into physicians on their own initiative, how they're coming forward to solve problems, and how we are keeping people, providing care in communities, in home, and keeping them out of emergencies, and they're not small numbers.
With
So-
all due respect, it's unacceptable for witnesses to come to this committee, the Public Counts Committee, the committee of the House that looks at the finances of the province without any kind of financial figures. I mean, to me, it's just unbelievable. It's frustrating. I know my colleague mentioned this over the last number of months, trying to get answers. I would hope that those numbers would be available. You must have a cost figure to implement one clinic in the province. I know it's going to be different region to region, depending on the number of people involved, but there has to be some kind of planning. And the one thing that is very frustrating, and it gives cold comfort to that senior who's living in Weymouth or who's living in Sydney, who's living in Yarmouth, who has no access to a family doctor, who realizes and sees their emergency room closed more often than not, and we keep hearing this from government. We have a plan in place from years ago, a model that did exactly what the department has talked about over and over the last 3.5 years, engaging the community, making a change that will improve access to not only emergency care but primary care. And we haven't seen any action from this government. A lot of the initiatives that has been mentioned today have been enacted under the fragment and disjointed system of the 9 health authorities. The 811 system, 8 collaborative emergency centers across the province, paramedics working with long-term care patients to hopefully keep them in long-term care, not visiting the ER. And I can go on about these initiatives. They're all good initiatives. They've been going on for a number of years under a fragmented and disjointed system. And what is not seen is, I think, a priority placed on what is the real issue here and how do we move forward. And cost has an effect on how to implement these new changes. So I find it unbelievable that we can't get costs to how much cost it's going to be to see these new clinics open up. One of the recent in the media, not just recent, but over the last year or two, I know another well-respected emergency room physician, Dr. Campbell, who is the chief of staff, I believe, at the Halifax Infirmary, not only just recently, but in July, talked about the issue of patients in not only ER, but in the hospital who are there because they don't have nowhere else to go. They need long-term care. And since this government has taken over, we know, well, I know, how many long-term care beds have opened up, new long-term care beds have opened up. So maybe I'll ask the deputy, I know you're recently new to the position, but are you aware of how many new long-term care beds the current Liberal government has opened since they took power 3.5 years ago?
Ms. Parrott.
Thank you, sir. I'd have to check on the number of new beds that are open. I can tell you, because there's a lot of proactive activity on this front, that since 2015, the wait list for long-term care has been decreased by 54%. And as we know, people actually don't want to be in long-term care as much as they want to be cared for in their home and stay in their communities, in their home community as long as possible. On the home care support front, the wait list is almost eliminated. It's been reduced by 91% since 2015.
But the people in the hospital, the people in the ERs, those frail Nova Scotians that Dr. Campbell talked about, they don't need home care. They're past that point. They need long-term care placements. And I believe the number's 0. There has been a moratorium placed on new long-term care openings here in the province, and that's having an effect that is hurting not only access to emergency care in Halifax and around the province, but the ability for emergency room physicians to do what they're trained to do, take care of emergency situations. And now we have people who are patients who are in the department who should be either admitted to the hospital, which they can't do, or placed in long-term care. And we've seen this cycle over and over and over again. And it was back when I first got elected in 2003 when the Conservative government for years and years denied the fact that opening more long-term care beds would address the issues that we see in our hospitals. And they seen the light at one point. I think they initially said they'd open up 1,500, and that was a major issue going into elections after elections, with people waiting on wait lists, and finally the government addressing it and opening new long-term care beds. This is the first government in about 10 years that has said, no, that's not an issue. We're going to put the emphasis on home care, which is extremely important. I know how important home care is, but there is a point that people can't stay in their homes longer. And they're ending up in our ERs, if they're open, and they're ending up in our hospitals where they should be taken care of in a long-term care facility. So do you agree, have you looked at the 8 collaborative emergency centers that have been opened up over the last, well, since 2011? Would you agree that they've been it was a positive change to do that, to address a need in rural communities? Or have you looked at the report that was commissioned by this government and previous information around how important collaborative emergency centers are to communities like Pugwash, Musquodoboit Harbour, Musquodoboit Valley, New Waterford, Parsboro, Spring Hill, Tatamagouche, and Annapolis Royal?
Ms. Parrott.
Thank you, sir. Yes, I absolutely agree. I think that what's important about and what I understand from the collaborative emergency centers and what the evaluations have demonstrated is really the collaborative care that's come out of them and the problem solving. Because I would also point out, with respect to your comments on long-term care, is it's that type of community or collaborative capacity in the community that's solving a lot of other problems. Because the wait list for long-term care is now turning over. In 2016-17, we're able to turn over that wait list, so we're placing people as fast as people are coming on. There's been incredible progress on that front and a move to community care. So I don't want people to, again, feel that there's no progress. I think there's very positive progress. I'm not going to dispute that it's fast enough for what people are coming to expect.
Are you able to provide the committee with the most up-to-date wait lists for people on long-term care and the time that they're actually waiting? Because we know the exercise the minister took to eliminate people from the wait list. You know, if they weren't going to take their first placement, they were being told within 24 hours they'd be off that list. So that was a good way of eliminating a bunch of people on that list. So I wonder if you could provide us with that. I don't need it right away, but provide us with...
I'd be happy to do it right away.
Excellent.
Let me do it. On March 29th of this year, in the community, there were 945 individuals on the wait list, and in hospitals, there were 191 people on the wait list.
What's the average time that 945 people, what's the longest someone has been waiting? Do you have that number?
No, I don't have the longest number, but I do know that those wait list statistics are down by 54% from 2015.
I mean, that's great for you know, when you put it on a chart, but it's no good for the 945 people who are waiting. I mean, if you're still waiting 2 years, you're waiting 2 years. Doesn't matter if the list dropped by 1,000. I mean, that's what we're missing here, and that's what government is missing. Is it's great to throw those numbers out. It's great to have the talking points. But for those 945 people, many of those end up in the emergency department down the road here in Sydney, in Yarmouth, and that's what's contributing to the overall crisis that we see in our emergency departments. That's why we have the report from one of the biggest unions here about code census in Nova Scotia. And it's interesting to see just in a short 13, 14 years, code census. I don't believe, you know, the last year of my service on the ambulance that I recall code census. And some 13 years later, it's an hourly thing, I think, now, and that should be concerning to the government, and we should be listening to people like Dr. Campbell who know exactly what's going on in the emergency department. You and I are sitting here in the legislature, we're in our offices, we take phone calls, we get all the paperwork and all the data and to go through, but people like Dr. Campbell and others are on the front line, and they know. And I don't believe the current government is taking that knowledge from those experienced professional people who are providing care and trying to provide adequate care. We're not taking it serious enough, and to sit here and say 3.5 years into a mandate that we still don't have a new collaborative clinic for access to primary care in the province. And I know you say 8, and I don't know if I've actually even received the 8 that was mentioned about a month ago or a couple weeks ago. Do you have those 8 that you keep mentioning? Which ones are open now that people are utilizing?
So we have 30 seconds. Ms. Knox.
So I think the number you're referring to, that there were 8 collaborative care centers that are fully functioning in a total interdisciplinary perspective. We did provide that information. I didn't bring it today,
Okay.
but we can provide that information.
I might have missed it, but
I think we did
I'll look
already
for it. I
provide
know.
it the last time we were
Okay.
here.
Okay,
Yes, I'm
time
sure.
has expired. The clerk has noted the information the member has asked for, and we'll move to the Liberal caucus for 20 minutes, starting with Mr. Porter.
Thank you, Mr. Chair. And just noting the time there. Thanks for being here today. This is a very important topic, as we've been hearing about this for a long time, and you suggested in the opening statement, the deputy has, that this is a decade-old problem, and I would agree probably more than that, having come from a world previous to this one that was in healthcare. I saw Dr. Travers this morning for the first time in a very long time. It was nice to have you here as well, especially given the role that you're in, a very important role. I'm interested in we hear a lot of talk about the primary care, and I would like to ask, I think to start with, how many people, and maybe Dr. Travers, you can speak to this, or the deputy or anyone for that matter, but you may be more aware than any. How many people in Nova Scotia who are sick, and you know the description of sick that I'm referring to, who are sick or in need, emergencies, how many go without?
Dr. Travis.
Thank you for the question. Can I please clarify, go without?
Go without as in they are not seen immediately. When people are sick in the province of Nova Scotia, how many people are not seen immediately to be treated?
Mr. Porter, if I can answer that in the context of EHS, I believe they don't go without when they call 911 and they build an emergency call from the community to hospital. I think Nova Scotians should be very proud of that fact that the 911 system is the first point of medical care for every single Nova Scotian, regardless of their emergency. And there's a chain of survival that is built from the community to the hospital. If I may take that hat off, and I'll put on a physician hat of working as a staff physician in the emergency department, I don't feel that patients go without for the types of patients that I see in a very busy tertiary or quaternary emergency department here at the Halifax Infirmary. I think that the places we're practicing are always being tested, from the stretcher to a hallway to an ambulance stretcher, but I'm confident that patients don't go without. We collectively, as a staff physician and the team in the hospitals in the emerge, and nurses and paramedics and social workers and pharmacists, are working aggressively to meet that patient's needs and doing it safely.
Great, thank you, and I couldn't agree more. And this has taken me to where I want to go with this initially. So prior to the amalgamation of the ambulance service in this province, I had the pleasure of working in the old system as well, and I know others in this chamber have as well. I would also have made the same statement at that time. Although things were different, there were 50, 52 operators, whatever it was, when we were called, people got the best care that they could be provided, and they got it instantly, and they were taken to a hospital either in their community or the Q or the VG in those days or wherever, and were given immediate treatment. Nobody went without treatment. That took time. That started quite a few years before it finished. That was a lengthy gap in the beginning. I believe it was Dr. Jim Smith may have started that in the mid-'80s or so. And it carried on through Dr. Ham and him as Premier, and it carries on today, even building, and it took well past the year 2000, I think, before every part of that ambulance service had changed and become what it is today. And there's a lot of steps in that. We have seen our 9 district health authorities now come into one. That is a large transition as well, but we are 1 million people, less than 1 million people. And what we do know is The larger transition of those 52 ambulance operators at the time came into one, and it took time, but it only got better as it went along until it reached a peak of being one of the very best internationally. It's been recognized, as we well know, in an accredited service, with very, very good people working in that system that, by the way, worked in old days in that system and helped build that system into what it is today. I find the transition, when I think about that very thing, moving the district health authorities into one, big task, no question about that. Issues along the way, no doubt there are. There are in anything you're doing when you're taking that, that huge administrative piece to task. But the efficiencies of that, I'm going to assume, and I'm watching, get better and better and better and better, and that will continue as we go along. This will be a very fine running machine. Not that it isn't now, but as it becomes one, becomes tighter, why would we be doing business differently in Yarmouth than we would be in Cape Breton or Halifax or anywhere else? That's what we saw in old days. You did things differently, different equipment, different procurement. I remember all that very well. And as we transition into one, things have to get tighter and tighter and tighter, and that meaning better and better and better and better. And it will run and does run very well. So I think that the transition to one district health authority is a good thing. Again, we're talking less than $1 million. Go and compare ourselves to Toronto as an example. How many people in one district health authority in one of the larger, or any city, and many, many, many more, but they do it and they do it well. So I think there's an advantage to being there. It does take some time. The community clinics that we see around, it's something I've always believed in long before we get into the collaborative model, and I guess maybe it's still described even in those days. And I'll use the one in Windsor as an example. It's up behind the hospital, the Bazant Clinic, and there were a number of physicians who owned that building, but there were a number of doctors in there, and there was a clinic on Monday night and every day of the week for an hour and a half, 2 hours, whatever it was. People lined up, they went in 5 or 10 minutes, they were out because they were ENT things. They weren't long, you know, you needed a script for this or for that, or they were minor things, and that is a process that worked very well. Recently, 3 weeks ago I think now, I went to a clinic in Windsor that is the Lawton's Clinic, I'll call it for lack of a better term, but the new clinic by appointment. I called that morning at about 8:30, 9 o'clock, and I was in for 11. Saw a doc, was all good, saw a paramedic first, did all my triage things, vitals, etc. Doctor come in, did our bit, thanks very much, and out the door, very timely. So when I hear about access to primary care not being available, I struggle a little bit with that, because when I think of primary care, I think of instant, sick people who need to be seen, whether they're emergent sick by way of an ambulance ride or something like that, or trauma, cardiac issues, etc., or whether they're sick, you know, for a week and it's a flu or it's whatever it is, but I got to get to the doctor and get something. I need a script. I got to get something for this. I don't see great delays in that happening. Am I wrong on that? Am I missing something, or are we just living in one of the best areas in the province, which I would agree we are, but we have access. I don't know. I don't hear from many people on this, you know, not on those issues. Am I missing something here? Or I don't think I am. Things seem to be running. Nothing is ever perfect, and I'm the first to admit that. I mean, nothing is ever perfect, and anyone who thinks we're in utopia should step back and have another look, in all honesty, because we're not. But I'm just curious, what am I missing here? Is this not the model that we're moving toward? And Dr. Travers, you can speak to it, but the deputy or Ms. Knox or whomever can speak to it. I don't care. Is there something different in other areas of the province that we're not focused on the exact same thing? I know that was lengthy, and I apologize, but...
Ms. Knox.
Thank you very much for that. And I think what you're highlighting is that we need to celebrate with Nova Scotians the good support that is available to them. There is a lot of really great work happening by very dedicated doctors and health professionals around this province. And the opportunity we do have is to learn from all of them and to spread the really good strategies across the province. So, but I will say, we know that there are areas of the province that have access issues to primary health care because physicians have left. And that, I've been in this system for a while, and there's different, over the years, there would be different parts of the province that would have this big challenge. And it is because suddenly. We have people who are at the end of their career and are going to leave, and we have to plan for that. We need to get into a better position working with all of our practitioners to plan together about how they live their careers and how we plan to keep positions full and address vacancies as they occur. But I thank you very much. I think that oftentimes we don't talk about the good things that are happening and the really wonderful programs that have developed with communities, with interactions with communities and their practitioners around this province. So as our deputy has said, we have great foundations. We have some challenges, and as we plan and spread expertise across the province, we plan together and have experts who are in our province helping others learn their approaches. It's really a good thing.
Thank you for that. And it kind of takes me to a couple of places here I want to get to. And I know that there are areas, and have been for years, and they seem to be, for whatever reason, similar, where there are struggles with emerges, or there are struggles with maybe getting clinics set up. I'm not sure. You know, I think about, you know, if we hear a lot about Shelburne in the news from time to time, and they struggle with their emergency department. Okay, that's the emergency department, we understand, or there's X-ray shut down or something. So when I look, and it doesn't matter where I pick, we're very fortunate, as I said, where I come from, but the plan, though, across the province, I guess what I'm stressing here, the plan for community A versus community B, C, D, and so on is the same. And that's a question as much as it is a statement, I guess. That planning, when we sit down and we talk about that, and we're talking with physicians and we're recruiting and we're doing what have you, is it the same province-wide, or does it differ from community to community for some reason? And I guess my thought is, I don't know why it would differ, because a Nova Scotian in Shelburne is no different than one in Glace Bay or in Windsor. So I'm just looking for some clarity on that. Maybe Ms. Knox, feel free.
Ms. Knox.
Thank you for that as well. Our approach to planning for community needs, we call it a community-based planning approach. We can use our information that we have about who the population is, what we know about how they access health care, what are the issues that are important to them, what are the challenges in our local communities. We do know, with the support of the Support for Patient-Oriented Research Unit at Dalhousie University, we actually can drill right, they have helped us drill right down to the community level to see what are the demographics of the community and what are the health issues in local communities. So we have been able to show that there are a couple of areas in the province that are somewhat different, with a higher burden of chronic disease. Generally, we have many of the same issues, because we have across the province a high burden of chronic illness. There are, however, population is different somewhat in each of our communities. So our approach is, from a community-based support, the team-based care in local communities is the model that we believe is important. That team begins with doctors, nurse practitioners, and family practice nurses. The rest of the team needs to be up to the community, the practitioners in that community, to be understanding who their community is and who else needs to be involved in the care of that local community. So I wanted to say there is flexibility, because there needs to be, depending on what are the skills of the team, what types of skills would be needed to balance out to support a local community. By that approach, we would say then that we are responsive to the population that is there, and community members are part of that planning. We've had a very good example of that. I'll just be as brief as I can be in looking at some of our communities. So in Digby and surrounding areas, who are the surrounding populations in those villages and in the rural surrounding areas. That may be a different solution than down the road in Middleton, where I know very well, where we had long-standing issues of access to primary care for years, and we really worked with the community in terms of what are the needs and how do we support practitioners to come in there. So that solution would be somewhat different, because it's unique to the community. The last area, we would say, in looking at Pugwash, when we looked at went in with the community group, the physicians and community members, and talked about what we know in that community and what resources should be there, and what kind of facility do we need to the future. The big, very important piece of that information was to have a discussion about the lived experience of people. What's travel like? You know, what's the age? What kind of supports do they have? What other assets are in the community? So I'm thankful to have that opportunity to say we have a framework and a general plan, but we can be flexible at the local community level, and that's not just the health authority, that's working with the community. So thank you.
Okay, thank you. I've only got 6 minutes left. This is going by quickly here, but I want to get a couple other things in. The late Dr. Fred Aiken, who brought me into this world, I don't know how many patients he had, but how things have changed. Fred Aiken worked 24 hours a day, near as I could tell, whether it was at the hospital, his office, but we know that that is changing. We know that care is still required 24 hours a day, hence this emergency system that we have and so on. We can even tell you from historical data, from where I left in the communications center, that was being measured almost when calls will come in and how many during a time of day. Are we, and I'm trying to get 2 more questions in here quickly, are we measuring those statistics in communities as a whole, whether they're through emergency room visits or clinic visits or doctor visits? Are we doing any of that at all?
Yes.
And we're doing that across the province on a 24-hour basis, on a night basis? How's that working?
So we do know, and maybe Paula Bond may want to add to this, we do know what is who's accessing our emergency rooms over hours of the day. Okay. Yes, over the 24-hour clocks, we do know that. We also do know the entire population of family physicians in this province, what their population looks like, where they live, how far they travel to come see their physician. We've been in every single practice in this province talking with them about that. So yes, we do have a very good information about how people move around and access services.
Okay, so, you know, we hear lots of talk about physician recruitment in the province of Nova Scotia. Again, there are a lot of areas where it hasn't been, you know, an issue or a problem. I'm not sure what the numbers are in specific communities. And I guess I think about how lives have changed, how physicians have changed. We hear a lot about physicians today. They want to work in the collaborative practice. And having visited that one a few weeks ago myself, I can kind of see why. It's pretty neat how it all goes. There's a lot of supports there. In talking to younger physicians that I know, I think that, you know, there's a lot of new technology since the man who brought me into the world has come along. They want to be able to have access to all of those new pieces of equipment and, you know, something as simple as CTs and x-rays and sharing of information. I guess my question too is around, with amalgamation becoming one system or province-wide, there's a technology piece that goes with that, the sharing of information. You type in my SIN number and anyone in the world can tell me anything about me in this country. You know, it's easy. How come I can't type my health card number in and you do the same thing about me from a medical perspective? Where are we with that? I know it's probably all part of the greater provincial amalgamation piece. I see that as great value as well. Are we on that road? And because I'm running out of time here, maybe yourself or Dr. Travers or somebody can speak to the investment that we're trying and attempting to make in the recruitment of physicians, and what are some of the challenges around that? Is it people want to work 8 or 10 hours a day, not 24, you know, and have a life outside of what they do? Like a lot of young professionals, are they both working? It's not like it used to be. You know, in the Fred Aiken case that I referenced, his wife Mary was his secretary. They spent all day, every day together. You know, it's a different scenario. So I know I've touched on a lot. I've only got a couple of minutes left for you to answer, so I'll give you that, but I would appreciate what you can offer.
Ms. Knox.
So quickly, I'll say we're very focused on what is the kind of working situation that young practitioners want. First, I want to say young practitioners want to care for patients. They're very committed. The commitment of 50 years ago is still in these practitioners.
Absolutely.
We need to say that and be very clear about that. So when we're recruiting, we recruit to what's the kind of place that you want to live. We're now able to take you right across the province. We help understand with them what are the kinds of supports that they that are helpful to them. We've had the opportunity of talking with many physicians at various stages of their career in terms of the mentorship and support from other physicians, the working with collaborative colleagues of different disciplines, and the kind of community that they want to live in and bring up their family. So we take into account all of those kinds of things. We also have incentive programs that are available because many of them come with a very big burden of debt, and so some of that will be helpful to us as well. So it's a whole variety of what makes this a good place to live, to work, to use the skills that you've worked so hard to develop.
Thank you. And with just, Mr. Chair, how much time do I have left?
40 seconds.
40 seconds. Can you speak then briefly, Ms. Knox, about the other part I mentioned around the technology piece? You know, the health cards. If I go into a hospital in Yarmouth and I have some history and I'm in a, I don't know, some kind of traumatic event or something else happens, where's that?
So I think I'll ask Deputy Perrette to speak to that.
Ms. Perrette.
Thank you. And the short answer is that's an absolute priority, having one health record for every person in Nova Scotia. It's a priority of the department, and work on that front is moving ahead, I think, in a good order.
Thank you very much. Thank you, Mr. Chair.
Thank you. We'll go back to the PC caucus for 13 minutes. Mr. Houston.
Thank you, Mr. Chair. Just as we were speaking, I heard from a few doctors that said they haven't seen their share of the $6 million. I just asked if the deputy can report back to the committee when those checks actually went out. I'll ask the clerk to take note of that. So looking at the Health Authority webpage today, Pugwash Emergency Department is closed today. The New Waterford Emergency Department is closed today. Spring Hill Emergency Department is open today, but it was closed yesterday, and it'll be closed Thursday, and it'll be closed Friday. Parsborough was closed on Saturday. Northside General was closed on Saturday. New Waterford was also closed last Friday. Last year, we had a record-breaking year for, and I'm talking about the fiscal year for the government, from April 1st to March 31st. Last year, the year ended March 31st, 2016, record-breaking year for emergency room closures, 938 days was a report I received. Did we break that record this year? The year is now ended. Can you tell me how many days emergency departments were closed and the year just ended?
So, Ms. Knox.
Thank you. We believe that we've closed the year 16-17 with 159 hours less of closure.
Okay, so not closed quite as often, a little bit better for the year. Okay,
yes.
but in the same ballpark, I guess. When you're talking about 938 days, you're talking about maybe that was 935 days or something. But maybe we can get that report, Mr. Chair, or ask the clerk to take notice of the number of days emergency rooms were closed. Does it cost the province more when somebody presents at the emergency room as opposed to when they go and visit their family doctor? Does it cost more?
Ms. Knox.
The emergency room is funded very differently. We have staff that are there 24/7. So if 10 people arrive or 12 people arrive, we say that we pay the same price. My understanding, depending on access to family physicians, I can ask Deputy Minister Perrette to talk about that.
Do you have an average cost of an emergency room visit in the province? What is that average cost?
We
Okay,
can
we'll
provide
go-
that. Tanya Penny can provide that.
Okay. Ms. Penny.
It actually varies according to the facility, and it depends on how many staff are on. So obviously, the tertiary care center is a bit more costly than a small community facility that has 2 registered nurses. So it averages somewhere between $89 a visit and $210.
89 to 210, and the fee code for family doctors for a regular visit would be less than that or more than that?
I'm sorry, I wouldn't know the answer to that question.
Ms. Penny.
Somebody? Deputy, maybe?
Ms. Parrott.
That's information that I have to get for you on an average. You're asking for an average visit cost for a family doctor?
Yeah, there's a fee code. If you go to your doctor and you're there for whatever, he puts a fee code in and he gets paid. And what's the average of that? Would it be less than 89? Would it be less? The doctor gets paid. Would it be less than $89 or $210, like that range?
I'm going to get you that figure.
Okay, you're going to get me the average.
I'm going to get you a figure for an average family physician visit.
Okay.
and we'll have to probably explain the context that we work out average in.
Okay.
So that you understand.
How many people visit emergency departments in Nova Scotia last year?
Ms.
How many
Penny?
emergency room visits do we have?
Ms. Penny?
In total,
Yeah.
across the whole system? I don't know that I have. I'm not sure actually that I have that today. Do we have that? Sorry.
Ms. Knox?
Yeah.
Okay.
I'm just not, sorry, I just don't have it here today.
Okay.
Okay.
The clerk is noting all of this to get back to you.
Okay. What I was wondering was how many people visit the emergency room that don't have a family doctor. That would be a statistic that should be known. That's probably marked right on the admittance form or something. How many people visit the emergency room that don't have a family doctor? Do we know that number?
Ms. Penny?
Sorry, I don't know that today, but it is certainly something that we could find out.
Okay. How many of the people that visit an emergency room in the province that don't have a family doctor are visiting the emergency room for a reason that they probably should have gone to the family doctor for?
Ms. Penny?
So when you visit an emergency department in this province, you're triaged according to the Canadian Triage and Acuity Scale. And so what happens is that you get triaged either level 4 or level 5, depending on what brought you in that day. So those leveling and separation of those levelings is certainly that we can provide you with from a data perspective. It would take us some time to go into the actual Meditech and STAR systems to figure out if there was for example, you headed to your family physician for a script renewal. It would take us some digging to actually get down to that level of data.
Okay.
But there is some assumptions that you can make from a CTAS 5 perspective.
What I'm driving at is there's an actual dollar financial cost to the province for people not having access to a family doctor and are instead presenting at an emergency room. If it's more expensive to have them go into the emergency room, and we have the statistics available to figure out how many times that's happening, then we can figure out the cost. And those are the types of things that I'm interested in. Quite frankly, I'm surprised that the department's not interested in. Like that's a type of analysis that I would have expected is pretty common as to this is what it's costing. I'd like to ask the clerk, maybe we can take a note of those things and we'll do the analysis ourselves, I guess. But Deputy, is that not information that would be of interest? What's the actual financial cost to the system? Just there's all kinds of social cost to the system for people not having a doctor. Tremendous social cost to the system. There's actual and financial costs that can be calculated as well. Is that something that would be of interest?
Ms. Parrott?
Thank you. We're very much interested in the cost of the system on a number of fronts. Your question's an interesting one because we would be looking at, I think it's CTAS 4 and 5s for those visits that probably could have been handled by a family physician. But I'm going to make a guess here that a number of CTAS 4 and 5 visits are going to be by people who do have a family physician, but they're going to an emergency department at night or on weekends. So I find it, as I say, the context of tracking that type of cost may be challenging, and I'm not sure what it would show us, but we'll take that away and have a look at it. But I think the other aspect of the system, and it does go a bit to my opening remarks, which were general. I wasn't necessarily talking about the Nova Scotia system, I was talking about the systems in Canada. We really need to shift to a concept of primary health care that is not simply physician focused. If we want to get different results and improve population health, so we want to improve points of access and collaborative care, and we are making progress on that front. So that people have access to nurse practitioners and the like that can do much of the work that a family practitioner does.
Okay, you have time of day. Okay, if that's a parameter you want to add to the analysis that they're visiting the emergency room because the family doctor's closed or something, you have all that. You have all those statistics. You know when somebody went there. Last week I asked for almost 20 minutes how many family doctors there were in the province before I really even got an answer. Today we just heard Ms. Knox just said that Not only do they know that, they know where they practice, where their patients come from, how far they travel, and all this interesting stuff. So this, you understand my frustration,
So there's
I'm sure.
1,000 family doctors in the province, and we'd be more than happy if you want to submit questions in advance too, to have more
Sure.
precise
Okay.
answers available.
Okay, earlier today you said that you referenced the number of 50. I think you were using the number 50 in the context of collaborative emergency centers, that the plan is to have 50. There's 8 now, but there's 50. Was that the context of, it was a discussion we're having with my colleague.
So what I made reference to is that there are 8 collaborative care centers that are fully up and running. But in total, in addition to that, there are 42 that are in various states of being stood up.
Okay, those are collaborative care centers as opposed to collaborative emergency centers?
They're collaborative care centers, correct?
Okay. Can we get a list of those 42 as to where
Yes,
they're
we
at?
can.
Thank you. Now,
And I'm told that we've already provided it in the former package. So
okay,
it should
great,
be-
thank you for that. There's an issue at the Northside Sydney emergency room with respect to the funding of how that emergency room is funded. Are you aware that there's an issue?
Are you talking about a fee adjustment that was made for emergency docs?
Yeah, so the fee structure going forward as to how much people would be paid to work in that emergency room, there's a new fee arrangement that will be rolled out eventually. There's an issue with how that's going to impact the Northside Emergency Department. Are you aware that, just first question, are you aware that there's an issue with that?
I'm aware that an issue was raised about a fee adjustment, yes.
Okay, and what it all boils down to is that that's a particularly busy emergency room in the hours it's open, because they see it's not open as long as some other emergency departments, but they are seeing as many patients as some other ones. So it's very busy in the time frame that it's open. So the way that the fee structure has been negotiated, it doesn't address that, I guess. So as a result of that, I don't know if it's a mistake or oversight or whatever it is, but as a result of that, it actually means that a doctor working in the emergency room in Northside Sydney would be paid less than if they're working in some of the surrounding hospitals. That's my understanding of the issue. Is that your understanding of the issue?
So my understanding of the issue and how I was briefed is as follows, that a number of emergency departments that are relatively similar, there was a concern expressed, and it comes about from the consolidation, that there was a high degree of variability in the rates that were being paid. And so in collaborations, you have the department, you have the health authority, and you have Doctors Nova Scotia sat down to address that issue. And in that context, the rates, there was an equity adjustment. So some rates stayed the same, some rates went up, and in that area, those rates went down. That has not been implemented yet because we asked the same questions that you're asking. When concerns were raised as to what's the basis of the concern and what needs to be done, and so there's additional time to look at that.
Okay, so you've asked them to sort that out, because obviously it's not going to make sense if nobody's going to work in that hospital if they can get paid more working at the hospital next door, right? That's the concern of the community, and that's your concern by the sounds of it. Would that be fair?
My concern is that when you make an equity adjustment, it should be equitable, and if there are concerns that it isn't, that we should have a look at that, absolutely.
Okay, so that'll be looked at, and the actions you've taken are you've delayed the implementation of the new.
I believe we delayed the implementation, and again, I want to make it clear that that was a negotiated rate adjustment, and I think all parties will say, yeah, let's make sure we got it right, or if we didn't get it right, let's talk about what we need to do. Absolutely.
Okay, thank you.
Okay, time is just about to expire, so we'll move to the NDP party for 13 minutes. Mr. Wilson.
Thank you, Mr. Chair. I know the recent announcement of the new collaborative care clinic in Digby, I think you mentioned it's supposed to open in September of this year. How much is that going to cost to open up that clinic in Digby? Do you have those figures?
Ms. Knox?
So I don't have the total cost here, but I can tell you what we've added in terms of practitioners. So we've added 2 nurse practitioners, and family practice nurse. And so that the rest of the people of part of that clinic were already practitioners who were there. And so it's really about how you bring the resources in that local health center, hospital, together and work with the team of 3 family physicians, eventually 4, 2 nurse practitioners, a family practice nurse.
So, and I know this might be out there, but does the province cover the cost of the facility currently? I know that has been the case in a number of them. I'm just not sure about the Digby clinic. So, is that something that is something that the province pays for?
We were very fortunate. The community built that community health center. Wonderful support, with some support from the province. So is that what you're asking?
Yeah, so is there an operational cost? Like, do we pay the heat? Do we pay repairs, rent, if there's rent? But if it's paid for, I would assume it's
I can
not.
check on that for you.
So there was no, with the announcement, there was no cost, there was no figure. I mean, I've been in the position, you make an announcement, one of the first questions usually from a reporter is, well, how much does that cost? I know you're saying for the position of 2 nurse practitioners and 3 positions of nurses. So there's no, you can't give me any figure that there's going to be an increased cost on those positions, so roughly.
So the physicians were vacancies that we were filling. This already was part of, so that's the really important thing. What has happened here is we've added 2 nurse practitioners and a family practice nurse. So the rest of the positions, the resources were already there available. As you know, in that community, we've recruited numerous physicians over the past decade, and they stayed for very short periods of time. So that's not new resources in that community.
So that's kind of the frustrating part, is trying to get a dollar figure on this commitment. So the government is committed to 40-some potential sites over the next, I don't know how long, because we're almost 4 years in now. So I guess they're going to ask Nova Scotians to elect them again to hopefully see those 42 positions or offices. I don't know how much weight that has with voters, but I know in the last election there was a commitment to increase the number of collaborative emergency centres in the province. There was 8, and there was a number of them announced. Stephen McNeil agreed to fulfill that, and today, as we sit 3.5 years later, they haven't. So how can we believe that that's the direction of the government? And I understand the position that everybody here is in. You're here to implement the government policy of whoever's in government. So it comes from the top, and I blame the current government for the inaction because you can only do what they ask of you. So why haven't we seen an increase in collaborative emergency centers? I know the Minister of Health himself, especially around the Lunenburg CEC that was announced, that he said that there'll be a definite date very shortly. That was back in October 2014. So why are we not seeing an increase in collaborative emergency centers when they were identified a number of years ago, committed to by the current Premier of this province, and we're 3.5 years in and we're still waiting to see what direction the government's going to take? Can you give us an answer why we haven't seen an increase in collaborative emergency centers in those areas like Lunenburg and in Cape Breton?
Ms. Bond.
Thank you for the question. So when the collaborative emergency centres were stood up, and as you know, there was 8 stood up, and that was done in collaboration with the community partners, with physicians and nurses and other community needs were taken into consideration. The lack or strengths of primary care in those communities were taken into consideration. After the first 8 were stood up, there was a review done with the previous team in the Department of Health and Wellness, and I actually sat on that review committee, and we looked at the strengths of the CECs, of which there are many, and we looked at where we are with the primary care in the further communities, such as Lunenburg, for example. We then decided to continue to work, as we became Nova Scotia Health Authority, with the communities, with the extended communities, as to where we would go next and what communities were ready for it. So I think some of I'd like to clear up, if I may, is that not every community thought that they wanted immediately to go to the CEC model. And so we worked with the communities that did feel that this was appropriate for their communities, and for the other communities that said, we want to wait and see if this works or not, then we appreciated that and said we'll continue to work and evaluate and decide with the communities, particularly the physicians and the nurses, and where the needs were. And that's what we continue to do. We are committed. There are different models, as you know, across this province. Not every community emergency centre is staffed in the same way, either day or night. The daytime model for Lunenburg would look something totally different. And one of the issues in Lunenburg is that there's an infrastructure issue there. And we're trying to work through that and as to what that might look like and what changes we'd have to make in that facility in order to accommodate. We have been making some really good progress with the Emergency Program of Care, which is now a provincial program of care, of which Dr. David Petrie and Dr. Sam Campbell are part of, as well as other physicians and care providers across the province. So we are committed to continue with this and to make sure that we learn from how the other CECs were set up.
So the million-dollar question is a timeline. I mean, how long do we wait? How long does government wait to act? And we've seen year after year an increase in emergency room closures. Yes, supposedly 159 hours less this year, but by no means would I say that's a success. That's maybe 6 days. So how long do we wait? I mean, all the evidence in front of Nova Scotians have seen an increase in emergency room closures, lack of access to a family physician, overcrowding in our ERs. We have the chief of the emergency department at the Halifax Infirmary indicating that there are issues here. So I don't get why we haven't seen a concrete example of this is what we're doing to address the issues of access to care on so many different levels, from primary care or access to a family physician to emergency room access and closures. Does money play a part of this? Have your hands been tied because the current government's attempt to get back to balance has limited the investment in health, that actually reduced it in the last year with a reduction in total health spending has reduced over last year compared to the year prior, and we've seen a continued reduction in that. Has that restricted your ability to address these serious issues that Nova Scotians have? And if not, then please tell me what is on the horizon to address these issues.
Ms. Parrott.
So thank you for the question. It's an important question. From what I've seen and determined, my answer would be no, that's not a straight line, that there is not progress being made on the building of a broad-based primary health care centre because of money, but money does matter. So going forward on any initiative, on the strategic planning front, on the operational planning front, we obviously are more and more focused on getting value for investments, and we need to do the value equation. And partly what you're hearing in response to the context of these questions is that we're also trying to fashion these responses to fit community needs. So you have a very detailed lens on how to build out primary health care, how to build collaborative teams, how to respond to population health needs, and progress being made that 50 of these teams are already in either fully stood up or being stood up. So I think that there's a lot of work at play, and so it's not a financial barrier.
So we're not. I don't believe that the government's going to be fortunate to see the position you're in with Digby. Digby has been for a long time very engaged from a municipal level, community level, raising money, incentives that the community has brought to try to attract physicians to that great part of our province. It's been a struggle for them for the last 15 years or more. So the government's not going to be in that position in every community. Rural communities are struggling with population, with resources. So how can you say that the financial component of this is not going to be something that's at play when I see a government underspending their health budget, reducing their health budget, and knowing that there are communities out there that cannot bring to the table what Digby has brought to the table when it comes to hopefully attracting physicians or nurse practitioners or other healthcare providers. So are you concerned that we don't have 41 other Digbys that have, I think have a step up, I think, when it comes to organizing, trying to attract and recruit and retain healthcare providers?
So what I'm saying is that we're going to approach this from a population health lens, where the need is and where the capacity is, where there's a state of readiness. And there's always financial considerations in doing that, but the financial consideration isn't the lead on it. It's the planning and the preparation and the costing, so that we do our due diligence to see that we have the full value equation set out in each and every case.
And I know I have a short amount of time here. I'd be remiss if I didn't go to Dr. Travis and ask how are things with the paramedic profession, and what do you see on the horizon for that profession to continue to contribute like they've been for the last almost 20 some years in the transition of what we have now than what we had a mere 15, 20 years ago?
Dr. Travers.
Thank you, Mr. Wilson, for that question. I'm very proud that the College of Paramedics has now been implemented, and it's a self-regulating profession effective April 1st. And I think the landscape for paramedicine, to keep paramedics within the province and draw paramedics from across Canada and elsewhere, is the evolving models of care that's going to be happening in partnership with nurses, in partnership with physicians. And I think these new pathways we'll be able to find provincially, regionally, but new pathways of care which actually will challenge the idea that every 911 call means an ambulance transport to the emerge. That's the shift that Ms. Pratt was talking about at the very beginning, and Nova Scotia is slowly moving in that direction. So I think it's going to be a very exciting time for the profession. And I think the key thing for transparency is that although we may expand the scope and role of paramedics,
Order. Sorry, we're running a little short on time here. So we're moving back to Liberal Caucus for 13 minutes. Mr. Stroink.
Thank you very much. I guess I have a few questions that I want to kind of have a chat about. One of them is just on the closures that occurred in Nova Scotia. At any time during this time, was any Nova Scotia at risk of not getting care?
Ms. Parrott.
So I'm going to refer the question to our emergency physician, Dr. Travers.
Dr. Travers.
So I'm going to be wearing my hat as provincial medical director for EHS, and I feel no, patients were not. I think for those big emergencies in those communities that had ED closures, there was safety for that community in the form of 911 and an EHS system, and an integration with a broader healthcare system, where there was a stroke, an MI, a pregnancy, a neonatal case. That recognizing emergency in those communities, we were able to build a pathway of care to the regional hospital.
And how would that care look like if there was an emergency in that situation? Like, how would it look? Like, if it was a neonatal incident, how would that be addressed in those areas?
It's an excellent question. I think some examples, it's the same pathway. Although they may have briefly staged at that hospital, the idea is that for these emergency departments or those locations or these collaborative emergency centers, when the model was built, it was always built on the premise that the sicker the patient was, the faster they were going to be shipped on. And during those times of closures, we worked as a system to mitigate risk to the communities by actually bringing the patient directly from the community to those regional hospitals, whether by ground or by the air medical system.
Excellent, thank you. And I guess with that then, do CECs work?
Okay. Ms. Summers.
Do the collaborative emergency centers work, so the 8 that we have opened?
Yeah.
So yes, those small communities were experiencing many closures and delays in accessing primary care. And that model of care was implemented, and we immediately saw a reduction in ER visits and an increase in primary care visits. And what it demonstrated was those communities didn't need more emergency care. What they needed was more primary care. And we certainly identified that through the evaluation very solidly. So the next step was, how do we then take the lessons that we have learned from opening those collaborative emergency centers and build it into the future? And if the future is all around collaborative care, and so we've taken those learnings and are trying to build primary care as the foundation of the system. And that's where we have gone with those centers.
So with that statement, do you have some stats that you can share with Nova Scotians in the sense of that the shift is going from primary care, that the CECs weren't emergencies, they were primary care visits? And so the stats, if you're saying that we need to go to collaborative care from a CEC model, then you must have some kind of anecdotal information to share.
So we track all visits to collaborative emergency centers, as we do to all emergency centers. And you can see we have the stats that show a reduction in the number of presentations to the emergency department because they can access primary care for longer hours into the evening and on the weekends when they need it. So that was the shift, is that those folks weren't looking for we're not looking for emergency care when they present it to the emergency. They were looking for primary care. And in the CECs, folks are triaged. If they do go to the emergency door and they need primary care, they're immediately triaged to primary care. So we've seen, and we know that primary care provided in a primary care setting is far superior than primary care being provided in an emergency setting. So that's been a real improvement for those communities, getting the right care in the right place.
So what I'm hearing is that the CECs might not be the model that we need to go forward with, and more looking at, and that's why we're headed down this road, is the collaborative care model is going to be more advantageous for communities like Digby that are going to have they're going to get more support within the community for the primary care versus emergency care.
Precisely. So as we've been hearing today, we need to now design more precisely around the needs of those communities. And we're learning that the needs of these communities was not specifically around emergency care. So therefore, the planning going forward that the Health Authority was talking about is around being very clear around what is needed in those communities and how do we build it for those communities.
Excellent. So thank you for that, because I think that gives a great clarity of why we might not be opening more CECs, because those needs in those communities are might not be addressed through the CEC model, but more through a collaborative care model.
Correct.
Yeah. And so with that, to me, that makes a lot of sense, and that's a smart way of making sure that our dollars go as far as possible, and that Nova Scotians get the care that they need within the community based on a primary care model versus a CEC model. So thank you for sharing that. And I guess with that expansion of doing care a little bit different, I mean, you touched on it a little bit more, but about how we're dealing with seniors who are in palliative care, right? I mean, that's a good news story, but in the sense that people are recognizing that from around the world. My understanding is someone's coming up from another country to have a look at this. Why is this successful, and why are people looking at us as Nova Scotian as a leader in this?
Ms. Parrott.
Thank you for the question, and I'll let Dr. Travers elaborate a bit on the components of the program. But because, and it's an important question, because Nova Scotians know, because the issues that I raised in my opening remarks were not specific to Nova Scotia, they're specific to health systems across Canada and partly around the world. And my point is that in solving them, and everyone is struggling with some of these issues, Nova Scotia is ahead of the game and has a base of experience that it's putting into play that is really demonstrating to the world how to do this. And palliative care, long-term care, the home visits, the Adopt a Senior program are examples of this.
So you're saying we're leading Canada in those areas?
I think in some of those areas we absolutely are, and we're seeing an interest internationally in some of those initiatives. And the credit goes to frontline staff.
Excellent. That's great news.
Dr. Travers.
I think to build on that point is that for communities, it's almost they're building these toolboxes of resources that are available. Some provincial programs like special patient programs and paramedics providing palliative care at home. But there's also these regional examples where we're learning from the communities about best practices. a senior in Truro or in Bridgewater who calls 911 who fall, paramedics can make a referral to the local falls clinic. And it's that kind of innovative thinking as teams that we're all beginning to coalesce. And as two large systems, two large provincial systems, we're coming up with these new patient pathways. And I think it goes to address Mr. Porter's questions about that benefit of being one large health authority and two systems being able to speak to each other about what resources and options are available.
Thank you. And I guess that kind of expands on, I mean, we're not doing it just there. I mean, I think the other one is in the ER here is you have this phenomenal rapid assessment program. And maybe, to me, that makes also a lot of sense. And I think if you can explain what that rapid assessment is, because to me, that's another good news in the sense of how we're dealing with emergency care and trying to deal with backlogs. So if someone comes into the rapid assessment unit, they're not going into the emergency unit, so we're not clogging up the system with this rapid assessment. So maybe if you can share a little bit about that, and explaining how that works.
Ms. Knox.
Thank you for that. I'll ask Ms. Penny to explain that.
Ms. Penny.
Thank you. The Rapid Assessment Unit in the Halifax Infirmary is what you are referring to, and it's a 10-bed unit that is off of the emergency department that is able or has the capacity to take referrals from community or other regional sites where patients in other areas of the province require consultation to specialty services. So rather than them heading to the tertiary care center to see the specialist, they actually go off to a separate unit. And so you're right, it keeps those patients out of a dual emergency department visit, and it streamlines their care.
So, and I've got one more because I'm trying to wrap this up as quick as I can. So now we have another crisis coming down our pipe, which is the opioid use, right? So how are we dealing with that? And there's a reason why I'm kind of walking you through each of these.
Dr. Travers.
I'm very proud that EHS is working with Dr. Strang and Public Health to mitigate the risk of opioid use disorder in the province as we prepare for this pandemic wave as it sweeps across Canada. And I think Nova Scotia should be very proud that we're leading the country in such farms as having just-in-time training for the take-home naloxone kits that such groups as Direction 180 are giving. And it's the type of thing which if a citizen calls 911, that they're actually taught how to use the naloxone kit they were given by the public health teams to save that person's life. And
I know we've expanded that quite dramatically, working with Mainline, working with other places. So this is another aspect of trying to get people, not necessarily who end up in the emergency room, but this is another form of treatment.
This is for the bystander given naloxone, but it's more than that. It's the idea of that same program would enroll their patients into our special patient program to facilitate their entry into the emerge, so that actually they have coordinated care even before they arrived in the emergency department, so they can get that continued redosing of the naloxone if needed, as well as direction towards mental health addiction counseling.
So what I'm trying to get at here is I've just kind of walked you through 4 pretty amazing initiatives that this government has led in the sense of changing healthcare and emergency care within Nova Scotia. And the Deputy Minister, you've said yourself numerous times in this chamber, you came to Nova Scotia from Alberta because we were leading and making a plan. And I guess, so this is an example of the great work that you guys have done in Nova Scotia to ensure that patients are taken care of. And I guess I just would like the Deputy to kind of expand on, this is the path that we're trying to go down, is it not? This is what we're trying to do for Nova Scotia, is look at things differently and expand on our emergency care so that we are ensuring that Nova Scotians in an emergency setting are taken care of with the utmost care.
Ms. Parrott.
Thank you. Yes, when you start to learn about what's happening in Nova Scotia, there's a collaborative and innovative spirit here that's very compelling. And the more you learn about it, the more you want to be part of it. Because I think that, I honestly believe that some of these complex issues that are challenging healthcare systems across the country, that Nova Scotia may be the place we solve a lot of them.
Thank you. I think that's my time, Chair.
There's 1 minute, less than 1 minute if you have anything else.
Okay, that's fine.
Okay. So we are running a little short on time, but if you'd like to make brief closing remarks, we can move there. 1 or 2 minutes. Ms. Parrott.
Well, I will be brief. I appreciate the invitation here. I appreciate the discussion. I think that these are challenging and complicated issues that merit a good discourse, and it's forums like this that are going to help move us forward. So thank you.
Thank you for that. And before we move into committee business, there's just a little bit of news to let the committee know. I want to recognize our Auditor General, who is here with us today. He attends a lot of these committees, and we appreciate that. He has been appointed to the Auditing and Assurance Standards Board of Canada for 3 years, beginning April 1st of this year. So that's a board that sets Canadian auditing standards and is made up of private and public sector representatives. He'll join 13 volunteer board of director members from across Canada, and that's a great thing for us because he'll be able to bring an Atlantic Canadian perspective to the board. So I want to recognize the Auditor General. Moving on to committee business, we have some correspondence that the members would have from the Department of Transportation Infrastructure Renewal, which is the information requested from the February 8th meeting. Any comments from members? Seeing none. The next piece of business is the Auditor General briefing. So on April 12th, our meeting topic includes the follow-up of the recommendations from the Auditor General from the February 2017 report relating to the departments appearing before the committee. And normally we would have a briefing in advance of this meeting. So in this case, it's based on the results of the follow-up report. So the committee needs to make a decision if you'd still like to have that briefing, which would have to take place in advance of next week's meeting. So if we really want to have that briefing, we just have to schedule it before 9 o'clock. So it'd have to be something like an 8 o'clock. So if no committee member feels strong about that, then we won't have that briefing. Okay. No comments from members. We'll go forward without the briefing. There was a motion from committee member Tim Houston about bringing in a witness from the last meeting. We ran out of time. I'm going to recommend that be put forward when we have our agenda setting on the April 19th meeting. So unless the member feels strongly that he wants that motion taken care of today, that's my recommendation. Okay, Mr. Houston.
I think we should. We can. I think we know the way it's going to go, and we'll bring it forward to agenda setting at that time. But the motion's on the floor. I'd like to bring the motion to conclusion. So
okay.
I have a motion to bring Danny Graham, Engage Nova Scotia, before the committee. Specifically, I'd like to see that fill the empty slot we have on April 26th. We can go to work that day instead of taking it off as a committee. So but that would be my motion. I'd like to have a vote on that, and I'll ask for a recorded vote on that.
Okay, the motion is, and I have it in front of me, that Danny Graham, in his capacity as Chief Engagement Office with Engage Nova Scotia, appear before the Public Accounts Committee along with appropriate staff from Communities, Culture and Heritage at the earliest opportunity, which would be, in this case, April 26th. All those in favor of that motion, please say aye. Opposed? That motion is defeated. The next committee business we have is, there's one more piece here. Sorry, Mr. Wilson.
Thank you, Mr. Chair. Just thinking about the Auditor General's follow-up, it would be beneficial. I think it's been the practice to have a briefing. I'm not sure how much time would a half hour be good enough. And if that's the case, I don't know if it's an 8:30 start. We could maybe come in for a half hour, have a quick briefing from the Auditor General's office.
We'll ask advice from Mr. Pickup.
I think a half hour would be plenty of time for that. Keeping in mind that, not to frustrate you, but a lot of the questions you will likely have will be, directed towards the department, but we can give a brief summary of what was in the report for you. So half hour is more than enough.
So I would ask that we schedule that in and meet at 8:30.
Okay, that's fine. I don't think that requires a motion, so we'll get the clerk to schedule early for that day commencing at 8:30 a.m. with the Auditor General we have 1 minute left. Very briefly, Mr. Porter.
Thank you, and I don't think it will take long. I would just like to move a motion that we would take Mr. Houston's request and move it to the agenda-setting meeting, which I think is next week, for further discussion. If
Yeah, we'll take,
whenever the agenda-setting
the
meeting
agenda
is, I'm not
setting is
sure the
April
date. I
19th.
apologize, the 19th?
Yeah.
I would move that we move that discussion to that meeting.
Okay, all those in favor? Against? That motion passes, and the clerk will note that. Okay, the last piece of business is the 2015 annual report for approval from the committee. The draft 2015 annual report for Publics Committee has been circulated. No changes have been provided to the clerk, so I need a motion to pass that annual report. Okay, all those in favor? Against? That motion passes. We are now adjourned.